I would just like to welcome you all, and it's my privilege to present our first colleague, Dr. Masur, that is going to present you a demanding patient. And before that, I would just like to thank the Camlog Foundation for the invitation. It's really a pleasure and honor to be here today, especially with such a fantastic, high-powered panel. Thank you. The floor is yours.
Aber mein Name ist nicht Ralf Masur. Ralf Masur ist mein Praxispartner. Er bekommt aber im Moment jeden Tag eine Tochter, kann deswegen nicht da sein, was man verstehen kann. Deswegen habe ich seinen Part übernommen. Ich habe den Fall The Demanding Patient. Ich habe es uns einfach gemacht im Auditorium. Viele waren gestern auf der Party gewesen, die Experten genauso. Deswegen wollte ich es nicht zu kompliziert machen, sondern das ist nur einfach eine Einzelzahnlücke. Aber wir haben höchste Schwierigkeit, das ist eine Frontzahnlücke. Es handelt sich um 3 Zähne, die problematisch sind. Das ist der Zahn 1,3, 1,2 und 1,1. 1,1 und 1,2 haben eine apikale Behärtung. Wenn wir uns die allgemeine Anamnese anschauen, es handelt sich um einen männlichen Patienten. Er ist 32 Jahre alt, gesund, raucht allerdings 15 bis 20 Zigaretten pro Tag. Von Beruf ist er Koch. Und wenn wir uns die parodontale Situation anschauen, sehen wir, dass er bukal an den beiden Zähnen 1,1 und 1,2 einen relativ starken Defekt hat. Er hat eine hohe Lachlinie, was erschwerend hinzukommt in diesem Bereich natürlich und das extrem aufwendig macht. Gott sei Dank hat er einen dicken Gingiva-Typ, er hat wenig Schmerz, nur geringe Entzündungszeichen, ansonsten keine parodontalen Probleme und wir sehen die beiden Zähne endodontisch problematisch, kann man sie erhalten. Der 1,3 ist ebenso apikal behärtet, wie kann man mit dem verfahren. Gleichzeitig insuffiziente Kronen an 1,1 und 1,2. Der Fall, man wird es sehen, ist schon ein älterer Fall aus dem Jahr 2002 und führt zu folgenden Fragen, die wir uns überlegt haben. Gibt es vielleicht eine endodontische Lösung? Wie wird mit dem Zahn 1,3 verfahren? Kann man vielleicht mit einer Wurzelspitzenresektion erfolgreich therapieren, was die beiden Frontzähne betrifft? Wenn die Zähne zum Extrahieren wären und wir müssten augmentieren, was bei diesem relativ groß erwartenden Defekt anzunehmen wäre, wie wird man augmentieren? Welche Zähne müssen wir ziehen? Brauchen wir ein CT oder DVT? Wie würden die Heilungszeiten aussehen? Würden wir verzögert implantieren, erst augmentieren oder das alles in eine OP setzen? Welche Zähne müssten wir extrahieren? Wie würde das Chirurgiekonzept aussehen? Die Kronen, die wir auf die Implantate dann, falls wir implantieren, setzen würden, wie müssen die aussehen? Vollkeramik, Keramik, Metallkeramik-Kronen. Wie viele Implantate würden wir in diesem Bereich setzen? Brauchen wir nur ein Implantat mit einem Rückengliedanhänger? Würden wir Zahn zu Zahn versorgen oder das Implantat mit einem Zahn verbinden? Welchen Implantattyp würden wir wählen? Welche Oberfläche? Brauchen wir ein Platform-Switching? Welchen Abutment-Typ würden wir wählen? Und, ich habe es vorhin schon erwähnt, welche Kronenart? Ja. Okay.
Thank you very much. And obviously we have a big problem here. And just one question before I put up the questions to our moderators. On the buccal side, periodontically, you said there were pockets.
Yes.
Deep pockets on both incisors. Sorry? 12 millimeters, okay. So, now we have several problems. We have an endodontic problem on number 13, and we have a huge defect. We don't actually know how huge this defect is. I would like to know, before addressing the problem, should we or shouldn't we do any kind of endodontic treatment prior to any kind of regeneration? Should we have a little bit more information in terms of the imagology area? I would like to start with you.
Maybe this is a very challenging case for different reasons, especially because we are in the aesthetic area and because of the endodontics problem, of course, but maybe it would be interesting to have any idea about the clinical situation. Do we have any pictures of the patient smiling or something like this?
So we have at least, we know that it's a high lip line, which is a problem. It's a thick tissue, but periodontally compromised, and also a defect, a bony defect that we don't know the exact extent. So it's difficult to know how much tissue we have around in order to be able to promote the regeneration. So should you go directly for a CAT scan before you would start planning the case?
I think so.
Dr. Tsai?
I think I agree that it's a complicated issue, but I think before we have the facial profile patient, we should look at the local etiology and also the oral etiologies. I think he's a cook, so maybe he's under heavy tension preparing the food or something, so maybe he has a processing problem, so that looks at the tooth 1-1 and 1-2, especially 1-1 has a fracture. Looks like that. So I think those two teeth are hopeless. But I think before going into any decision making, we should think of the etiology and try to control the bruxism, try to control the way the patient eats before you go into hopefully the implant therapy, GBI and combined implant therapy.
I find this is a very interesting case, especially as our two offices are about 20 kilometers apart. Could have easily been this patient would have hit our office as well. I actually would. Well, you said about ideology, I would start with the endodontic problem first, because as far as I have seen the X-ray, we're not totally sure whether the canine is also part of the problem. So I would actually start with
what would be your approach to deal with the endo problems of the three teeth?
Definitely, I'm not an endodontist.
Yeah,
well, first of all, I would refer the patient to an immediate endodontic, initial endodontic on the canine, see whether the problem actually changes, and then we would CAT scan, and then go on with that.
Okay. Eric, you're going to say?
I might be a little more radical, a little quicker. I think really 11 and 12 are hopeless. And I would get rid of the infection on the 13. Extract 11 and 12, and then after healing, have a CT scan to see what is the bony situation.
When we have very big defects, isn't that possible even though we know that we're going to extract those teeth, isn't that possible to go for an endodontic treatment before in order to try to recuperate as much as possible of the tissue that was lost before we go to the next step?
I think we should know more about the case, because at the moment I only have seen one X-ray. And because of a high smile line and maybe even if it's a thick gingival biotype, we should know about the symmetry of the gingiva, we should know if there is a loss of the papilla, and we should also know how deep the pocket is concerning infection, because if we have an acute infection, we should get rid of the tooth as fast as possible, even if we would lose soft tissue. And after that, I would do a DVT or a cone beam CT.
Yeah, because here I think the first diagnosis is this an endodontic problem, or is it an endoperio problem, or a perio
I think it's
problem?
both. I think it's both.
Now it probably developed into both afterwards. Yes.
To be honest, who cares at this moment anymore? Because both teeth, I think, are hopeless.
Yes.
So I don't think about if it's endodontic or perio. At the end, now we have to extract both.
Okay. So you would go also for the extraction immediately. Very well. So now there are a few that would do something to control the endo in order to recuperate before going for the extraction. Others would go directly for the extractions. So even if we have endo or not, we have now extracted both teeth. Okay, what is the next step? Pascal.
So I feel that at that time it's absolutely necessary to take some impressions to provide the patient with a walk-up in order to diagnose the need for bone reconstruction, which kind of bone reconstruction we need according to the prosthesis we plan to do, especially in this area. So, and also to come back to the previous questions, I mean, regarding the handle situation, in my opinion, the most predictable tool for handle diagnosis is CBCT. In order to identify any specific things about the anatomy of the canine, regarding the handle anatomy, etc. I think CBCT is really the first thing we have to perform in that situation. Also for the endo diagnosis, and also to plan the bone reconstruction according to the prosthesis we plan to do.
Alex?
I think the tooth 1-3 looks like need to root canal. But I think before we take out the tooth 1-2, we have to be concerned about the bony crest between the two hopeless teeth, and also between the 1-2 and 1-3. If we can keep the bony crest, then I think we can turn into the situation into more controllable GBR cases. So those are things that before we extract it, we have to be concerned.
I think that I think everybody agrees upon. Yeah. Very well. Would you also like to comment a little bit on the provisionalization of the case, because that's also...
I think one thing we haven't addressed yet is the compliance of the patient. As we said, 15 to 20 cigarettes a day.
Yes.
And as everybody knows, Dr. House, all patients are lying, so it's definitely more than 20. So what do we do? Even if we can do bone augmentation, what kind of bone augmentation? I think that's something we should address even before. What kind of surgery can we provide for this patient? Really comply to us? I think, well, we agree that this is not something that we put some granules in there and it's going to be bone. We're going to go for a little bigger augmentation block or whatever. So I think the compliance of the patient is something we should address before we start with all this.
So smoke cessation plan is definitely something to do right from the beginning. Okay, and I don't think anybody will disagree with that. So this is very important. Thank you. Eric, what would you do after the extraction and after having, you would take off CAT scan?
Yes, I would, and also I would think about the temporization.
Yes.
He has to go to the practice with teeth. And what I like to do is to take two orthodontic rings on the first molars, have a palatal arch, orthodontic arch, and bond two teeth on it, so that it's a not removable temporization device, and it's quite easy to remove and to put it back. And when it's certainly long-term, a long-standing procedure, the patient will be happy to already have fixed teeth when he leaves the practice.
Okay.
I would combine the extraction with a large soft tissue augmentation to maintain soft tissue, and then I would provisionalize with a kind of an adhesive bridge, which is fixed to, let me have a look, I would fix it to 2.1 and 2.2. Without any etching, only bonded, so I can remove it easily, I can fix it, and I don't have this arch, because I don't know anything about the oral hygiene, but even if he's a smoker and the oral hygiene is bad and he's a cook, he can't brush his teeth every 20 minutes because of smelling and tasting, I would bring in an easy provisionalization.
Okay, yes?
One question, Marcus. You said that you would do an augmentation of the soft tissue simultaneous to the extraction.
Yes.
Beside the anti-inflammatory therapy in advance, you will still have infection. How does it go with good healing?
I would combine it with antibiotic therapy. I would really raise a flap to clean the area, to clean the site, and then I would bring in really a lot of connective tissue.
Very much important is the flap design then. Would you go from palatal or would you go from labial?
I would go from palatal.
Okay. So, and then how long would you wait?
That's a very good question. That depends really on the patient. I think we all ask ourselves, how long do you wait? How long do you allow healing? It's individual, and I think it has to be decided in every case again new. And minimum time, I would wait 3 months.
Okay. So we have some time limitations, and before going to the audience, I would like to go around again, and we are now controlled infection of number 13. We have extracted the teeth. We have cleaned the area with or without any soft tissue augmentation. We are going to wait, depending on the healing of this patient. Also, we probably should wait until he stops smoking. And then, what are we going to do afterwards? And probably I would now ask also the reconstruction, and after the reconstruction, what would be your ideal treatment plan towards the end, because of time issues?
I don't know. The only thing I think we have really to keep in mind that implantology is not only implanted bone, but it's prosthesis. This is very important. This is the most important patient concern. To get teeth, not to get disintegration. He doesn't care about the disintegration. So what we have to do first is to plan the prosthesis using a wax-up, precise wax-up, to look at the patient, to make some trials without any gingiva or I don't know. But with wax, this is very important in order to diagnose what we want to do, where we want to have implants, where we want to have bone, where we want to have soft tissue. So I cannot tell you we have to do this and this, and we don't have any data. But the most important thing to do is really to go back to the need of the patient and with teeth. For this, we need a plan, prosthetic plan.
Alex?
No, I agree totally, but I think again, since we all agree that we have to extract the 1, 1, 1, 2, so we have, and also agree at least we need to do some punch technique to close the orifice for the gaining more soft tissue. But then I think we have to keep in mind, as soon as they extract the teeth, right, all the literature tells us that the bone is rapidly resolving, right? So that we have to think that still we have to plan like the wax up during the first 2 months, or at least at most 3 months of post-extraction and the soft tissue grafting to jump in to do the GBR procedure. But because we have wax up, so at least we have more idea of how much bone, the width, the height, how much we have to graft. I think the timing is also important.
So the recuperation of the lost tissue is going to be commanded by the wax up. Yes?
Well, let's suppose we have all this. We shall go on.
Exactly.
I wouldn't go for a bone block because as the site is very compromised, and we all know we lose a lot of bone on cortical bone blocks, I would go for a scaffolding technique that we take a split block and we use the internal part of the block as particulated and just a little laminar outside, and I would do this as bone grafting. The literature tells us nowadays that that's the most, chance to heal in, and also in a patient like this who is definitely compromised, smoking or not. And I personally, I would use one implant at the central incisor and leave it like this if it's possible.
Here,
and a cantilever to the lateral incisor.
Good. Please.
Basically, I would really consider to improve the situation before extracting, as you told, and I would also go for one implant with a cantilever, I think, because it's easier to handle. We know adjacent implants in the aesthetic zone, especially after augmentation procedures, is a big risk for aesthetics.
Eric?
I guess if the defect is not so big, I would do a getting bone regeneration and not to block or autogenous plates. And in such defect, I like to use allograft blocks, which give very good results and will give an easier surgery for the patient with the same potential results at the end. And I would place, I guess, 2 implants, because the space is quite wide, I guess, but again, we don't have this data as completely.
I think I would decide after a CAT scan if the palatal bone is existing.
Exactly, because that's one of the major problems. We don't know.
If we have palatal bone, I would go with a GBR technique, 1 implant, and I would use stem cells to enhance. We have very good results now. And I only would go for 1 implant because I think aesthetics is more compromised. You won't get a papilla here.
Okay. So now I would like to open the discussion for a couple of minutes to the audience. Probably I'm sure that there are people that are